This is the title, Side Effect Management and Real-Life Use of Triple Therapy with boceprevir. I want to acknowledge the people working with me, and I want to introduce that there are two different first-generation protease inhibitors, boceprevir and telaprevir. Boceprevir is given with 800 milligrams 3 times a day. The labeling is different between United States and Europe, and you will have more or less the labeling of the United States. That means that in the future you will be able to truncate in early responders treatment, also in partial responders and in relapses. This is a little bit different from the labeling for boceprevir in Europe. Concerning in drug therapy in general and the protease inhibitors specifically, we have new treatment regimen and we achieve high SVR rates, and the high SVR rates are associated with less treatment failure, which means less resistance-associated variants. However, there is no free lunch, and the improvement of SVR is accompanied by additional adverse events. So we have more side effects, and side effects may lead to adherence problems. But if we want to avoid the appearance of resistance-associated variants and want to keep high SVR rates, it's very important to manage side effects in order to keep the patient on drugs and to provide adherence. This is the analysis of the SPRINT-2 study, the treatment-naive phase 3 study with boceprevir. It's a global study, North America and European patients mainly. And what is very important is that patients who stick to 80% of the drugs, 80% of the time, have excellent SVR rates, and a decrease in SVR is associated with non-adherence. So if we achieve high SVR rates, this means management of side effects, and this is the subject of my talk. We have to keep in mind that triple therapy means 3 different drugs, and the protease inhibitors add to the side effect profile that we already know from interferon ribavirin. Therefore, the old problems of interferon ribavirin are still present. And this means bone marrow suppression, even interferons induce some anemia, and ribavirin adds to this, reduction of thrombocytes due to interferon, and reduction of white blood cell counts. We are well aware of the flu-like symptoms due to interferon, and that interferon may cause depression. In addition to these old friends and old problems by interferon and ribavirin, we have specific adverse events that come from the protease inhibitors. And there are specific adverse events for telaprevir, like rash, anorectal discomfort, and specific ones for boceprevir, like dysgeusia. Both protease inhibitors have in common that they cause anemia. And anemia is the most important single adverse event that is caused by protease inhibitors. In addition, we see nausea, diarrhea, neutropenia, and infections. Now I would like to concentrate on anemia. Here you see data from the overall safety analysis of the boceprevir trials, and you see that the anemia rate defined hemoglobin less than 10 gram increased from 29% in PEG-RIBA to 49% in triple therapy. However, the number of patients achieving grade 3-4 anemia is limited, with only 3%, and only 1% of patients discontinued treatment. We may remember that in boceprevir trials, in contrast to the telaprevir trials, erythropoietin was used and allowed and was even paid for by the sponsor of the boceprevir trials. About 2% of the patients required blood transfusions, which became evident when the patients had reduction of hemoglobin to below 8.5 gram. This, however, is the analysis of anemia in the well-controlled phase 3 trials with well-selected patients with strict inclusion-exclusion criteria. What are the results in real-life patients? Real-life patients have higher rate of discontinuation because they have a higher age. In the phase 3 trials, the age was around 53 years of age. Cardiovascular diseases, pulmonary disorders, and impaired renal function. This is by now a world-famous study, the so-called cubic study. This was coming from France. Both boceprevir and tenofovir patients were included, and the analysis of the safety profile was first published in EASL 2012 after 16 weeks of treatment, which means 4 weeks after the end of tenofovir and while being on boceprevir treatment. Here you see that the overall patient demographics show that the number of patients with genotype 1b was 61 over 39 or 60 over 40%, and that the mean hemoglobin was 14.4 or 14.8 to start with. The mean platelets were 150,000. All these patients were cirrhotic patients. All patients had cirrhosis. When we now look at anemia, we see that grade 2 anemia and grade 3-4 anemia was similar between tenofovir and boceprevir, and that EPO use was high, with 56 and 66%, while blood transfusion were given in 15 and 10%, which is much higher than the 2% seen in the phase 3 trials with boceprevir, where less than 10% had cirrhosis. So what are the therapeutic options to counter anemia? Number one is to replace the missing hemoglobin, meaning stimulate hemoglobin production by erythropoietin, or in extreme cases, giving blood transfusion, which was around 15% in the cubic study and only 2% in phase 3. Then elimination of triggering cause, meaning dose reduction of the responsible drugs. And remember that all the 3 drugs, boceprevir, interferon, and ribavirin, cause anemia. What about blood transfusion? Blood transfusion are limited in resources. There are several risks, including transmission of diseases associated with blood transfusion, and blood transfusion may require hospitalization. And normally, as shown on this cartoon and the graph of the single patient, the application of blood transfusion may only be a temporary effect. And blood transfusion should only be given in extreme cases with hemoglobin below 8.5. However, when we look at the 3 drugs causing anemia, and in patients with a hemoglobin above 8.5, then we should never reduce the protease inhibitor, because reducing boceprevir means increasing the risk of resistance development, which is closely associated with a decrease in cure rate in SVR. So now we discuss ribavirin dose reduction versus the use of erythropoietin. Erythropoietin has some disadvantages. It's not free, it costs. It has side effects by itself. The safety profile is discussed separately in hematological and non-hematological diseases. From the wide use of erythropoietin in nephrology and hematological disorders, we know that hypertension, thromboembolic events, antibodies to endogenous EPO may be associated with EPO use. In addition, the costs in Germany are listed below. So the other alternative to giving erythropoietin is reducing ribavirin. This has always been the primary choice in Germany. You've seen in France, they used more than 50% in the cubic study erythropoietin. In our own single center, real-life experience that I presented this morning, we never used erythropoietin in the 200 consecutive cases. Ribavirin dose reduction is easy to manage. It's certainly cost-saving, not cost-inducing. But what about the impact on antiviral efficacy? And the retrospective analysis of the 2 large phase 3 trials with boceprevir, here SPRINT 2 and RESPOND 2, has shown that independently, whether we give, in the case of anemia, erythropoietin, whether we reduce the dose of ribavirin, or whether we do both, or whether we do nothing, always the sustained response rate is higher than in cases without anemia. We learned this, and also genetic analysis have found a gene behind this, that anemia is a positive predictive parameter for an increase in SVR in cure rate. Therefore, it was logical to test prospectively the use of ribavirin reduction versus the use of EPO. This prospective trial was done for boceprevir because in the phase 3 trial with boceprevir, the use of erythropoietin was allowed, in contrast to the telaprevir studies. So this trial, which was mentioned this morning, is very important to note, because all patients who develop anemia, meaning who achieved less than 10 gram hemoglobin after 4 weeks, were randomized to receive either in the upper arm ribavirin dose reduction, or in the lower arm maintaining ribavirin dose and applying erythropoietin. If there were patients with a low hemoglobin below 8.5, they left the study and were submitted to a separate strategy, including blood transfusion. And the results are very impressive. You see that end of treatment, SVR and relapse were identical, independently whether you reduced ribavirin or gave erythropoietin. So the strategy is very clear. Ribavirin dose reduction should be first choice. It's easier to manage, and it has no negative impact on SVR. The worst that can happen to the patient is not developing anemia, because this is associated with a low SVR rate. Erythropoietin is an effective but very expensive alternative, and there is no benefit on SVR. So in summary, on anemia, you should never use boceprevir reduction. You should first use ribavirin dose reduction, and only in special cases should give erythropoietin, which in Germany is not approved for the use of treating anemia. But there's another question, and this is, what about the dose of interferon? We should not forget that this is a treatment of 3 drugs. And in the past, we already had to acknowledge that the old friends, the old side effects are still present, and that interferon by itself can cause anemia. And there have been studies like the IDEAL study comparing 1.0 against 1.5 interferon. And the dose of interferon has never been prospectively evaluated, which would be the optimum dose for use in combination with a protease inhibitor. And you see from this study that we could learn that in 1.0 we have almost identical SVR cure rate, but we have 5% less anemia reduction, meaning hemoglobin less than 10 gram. So interferon dosage does have an impact on anemia. There's no significant impact on SVR, and there have never been a dose-finding study for interferon in triple therapy. So interferon dose reduction may be reduced, another cost-saving strategy. So overall, the suggested algorithm for anemia management is, if there is less than 10 gram or rapid decrease during the lead-in phase, reduce ribavirin. You may think of interferon from 1.5 in the case of pegintron to 1.0, and also only to think of erythropoietin in special individual cases. If it's less than 8.5, then you should think of blood transfusion or discontinuing ribavirin and PI. Now, in the remaining part of my talk, I would like to discuss neutropenia, infections, and dysgeusia. This is, again, from the cubic study. All patients are cirrhotic patients. You see that neutropenia was seen grade 3 in 4.4% of the patient. In phase 2-3, it was 34%. Grade 4, 0.6, 7%. But infection, you only see in 2.5 and in phase 2-3, 2%. So overall, although there is neutropenia, obviously the risk for infection is limited. So the overall management, nevertheless, is that you should do interferon dose reduction if the neutrophils are below 750. You should discontinue interferon if it's below 500. And in certain cases only, you should apply G-CSF Neutrogen. A fatal cause is possible, and you need to monitor these patients with neutropenia individually. Finally, dysgeusia. Dysgeusia is a specific adverse event associated with boceprevir. It's a metallic taste that the patients report. About 37% of the patients treated with boceprevir suffer from dysgeusia. Unfortunately, there is no specific treatment. The good news is it's reversible. It immediately disappears after the end of treatment. The overall safety profile of boceprevir in clinical trials have been analyzed. The manuscript is submitted, and you see here that you have in particular anemia, as mentioned before, increasing from 29 to 49%, dysgeusia from 15 to 37%, so it was not zero in the control group. When we look at rash, there was no increase in rash. It was 17% in PEC-RIBA, mainly attributed to ribavirin. You have no increase in anorectal discomfort, and you have nausea almost identical. So the question is now real life. We have limited adverse events, and in particular serious adverse events, in all phase 3 trials of both protease inhibitors, boceprevir and tenofovir, and we had reportedly significant increase in the cirrhotic patients of the cubic trial. There is something else we need to discuss, and this is drug-drug interactions. You have heard this morning from Dr. Beck how important this issue is, and this is particularly relevant for special patient populations like HIV co-infection, patients under immunosuppressive drugs, post-transplant, and patients under self-medication with St. John's warts. However, here the internet is very, very helpful, and you have heard about this, that there is this University of Liverpool website that we also use in our clinical practice. So in summary, the new era of protease inhibitors led to markedly increased rates of SVR, about 30% in treatment-naive patients. However, there is no free lunch. On the other hand, there are additional adverse events and an increased prevalence of severe adverse events and new challenges like drug-drug interactions. New therapy regimens require a close monitoring and a specific management. This is very important. Anemia develops in particular the first 4 weeks, and we really have to phone for the patient if he does not come after week 4 for a checkup for hemoglobin. Especially in patients with comorbidities and advanced liver disease, this is of particular relevance. Real-life patients usually have comorbidities, which means co-medication. Adherence is an important factor contributing to SVR, and only if we have an optimal management of the side effects, we are able to keep a high SVR rates. Thank you very much.